Now, let us move on to the 7th symposium of the academic sessions on interstitial lung disease. I cordially invite the chairpersons, Dr. Vatsala Gunasinghe, Treasurer of SLCP and Consultant Respiratory Physician, and Professor Duminda Yasaratna, Consultant Respiratory Physician, to introduce the speakers.
I'm Vijit Senaratne. Good morning. We have gathered here to listen to the symposium on interstitial lung diseases. Actually, getting a patient with interstitial lung disease is a nightmare to most, if not all, chest physicians, because the diagnosis is difficult, treatment is difficult, and the outcome is not so rewarding. And it's over the last two to three decades, there has been considerable advancements in the field of interstitial lung disease, which has led to more refined classification of ILD. The approach to diagnostic approach to individual ILDs have improved, and also new guidelines have evolved. However, most of these ILDs, especially in the case of interstitial idiopathic pulmonary fibrosis, the outcome is very poor. To start off this session, we have Dr. Amila Ratnapala, Consultant Respiratory Physician. Dr. Ratnapala has a special interest in ILD. He actually has worked in a ILD center in John Radcliffe Hospital in Oxford in the UK. So I call upon Amila to talk to us on new horizons in the progressive fibrosing ILD.
It's coming to my eyes. Good morning, ladies and gentlemen. First of all, I would say it's a great honor and privilege to talk about ILD in front of my trainer in respiratory medicine. Is Dr. Vijit Senaratne, one of the role models in my life. And thank you so for that kind introduction. Today I'll be discussing about progressive pulmonary fibrosis. And I do not have any conflicts of interest related to this topic. And I'll be discussing about the definition of PPF and the pathophysiology as well as the treatment. First of all, I would say, there are many terminology which is used in the literature. They say it's a progressive fibrosing ILD, and some say it is a progressive fibrosing phenotype of ILD, and now the ATS-ERS guidelines in 2022, they have introduced new term of progressive pulmonary fibrosis. But the problem is actually in most of the centers, when there's lack of expertise, this creates a chaos. So most of the patients, that they either on premature introduction of antifibrotics, they don't get the maximum benefit of the immunomodulation. Either they are on suboptimum immunomodulation. That's a very common concept in our part of the world about triple therapy for ILDs, and that is low dose steroids, a low dose or moderate dose of mycophenolate and antifibrotics. But that is not the case. So I'll be discussing what exactly meant by the progressive pulmonary fibrosis. I'll be discussing two cases which are published elsewhere. It's a 51-year-old patient who presented in 2015 with progressive shortness of breath for 6 months duration. And he's a trivial ex-smoke of 5 pack years, but no significant exposures or no significant CTD features. And the CT scan showed diffuse ground glass opacities, and hence they have done a bronchoalveolar lavage which showed more than 40% of lymphocytes, and then treated with steroids as HP. And then there's a second cycle of history taking once they diagnose HP. So we do that often. We go back to the patients once we have the MDT diagnosis. That is called, it's a dynamic process. And we found that this patient had exposure to mold, especially at his home. So he was on steroid, and then as you can see in the orange line, that the lung function FVC improved with the treatment, and then gradually the steroids weaned off, and he moved to a new house there, therefore that he didn't have the continued exposure. But irrespective of that, when you wean off the steroids, and he became progressively breathless again. Had a CT scan again in 2019, showed evidence of early fibrosis plus persistent ground glass opacities, particularly ground glass nodules. Therefore, he was commenced on azathioprine. Unfortunately, he did not tolerate azathioprine. He was commenced on mycophenolate. And then disease was continuously progressing, as you can see, and then offered nintedanib at the end, but he progressed and ultimately ended up in lung transplantation. In my second case, he's a 43-year-old lady, and she presented to the vascular surgeons with Raynaud's phenomena. And the vascular surgeons referred to the team, and then we found that she has limited cutaneous systemic sclerosis with interstitial lung disease. However, she is breathless, NYHA class 2. And she was not offered any treatment because she is minimally symptomatic, and the CT scan shows early changes. And she was recruited for a clinical trial which studies anti-IL-6 treatment. And she was blinded for first 24 weeks, where there's some decline in the FVC. And then after 48 hours, 48 weeks actually, that we study was open label, and she was offered anti-IL-6 treatment. Irrespective of the anti-IL-6 treatment, she deteriorated further and she became more breathless, and her lung function declined further. And then the MDT decided that considering the CT scan, findings progressive inflammatory changes as well as some reticulations, they decided to start on immunosuppressive therapy where the disease was stabilized. However, she declined treatment in 2019 after 1 year. So these two scenarios, as you can see, there are two situations. First situation, we think that the patient could have received an ideal optimum treatment for the ILD. The second case, she was in a clinical trial, and we retrospectively evaluated. Actually, she was given placebo. She was in the placebo arm. So she did not receive optimum treatment in the initial phase. So therefore, when you are defining PPF, we should consider these factors. If I come to the ATS-ERS statement or guideline on definition of progressive pulmonary fibrosis, it says 2 of the following 3 criteria in a past year if the patient has evidence of fibrosis. If you go back to the clinical trials, like in BUILD, they have considered at least there should be 10% of fibrosis in the CT scan. But anyway, they're discussing about the worsening of respiratory symptoms or physiological evidence of disease progression or radiological evidence of disease progression in more than one of the radiological features, which I'll discuss later. So if there's 2 of these that we can consider as progressive pulmonary fibrosis. But there's a caveat. There's evidence of progression, but there's no mentioning about the optimum treatment. The patient can have the same scenario if the patient was not offered adequate treatment, as a second patient who was in the placebo arm of the clinical trial. And we see in our part of the world, in Sri Lanka actually, that when you don't have adequate diagnosis, when the patient is on incorrect treatment, the patient can progress anyway. But that is not an indication for antifibrotics. So what do you understand by progression of an interstitial lung disease? The progression could happen in the inflammatory element of the interstitial lung disease. This could present as acute exacerbation of ILD, which they present with worsening of shortness of breath, usually weeks to months' time, with diffuse ground glass opacities in relation to their reticulations. Or it could be the disease-specific inflammation, as our first patient, ground glass nodules, ongoing exposures and all, which can lead to disease-specific inflammation. Or it could be due to infections, as these patients are on immunosuppressants, as you know, that they are vulnerable for atypical infection. So this could be the scenario that we have to first think of, whether this patient is getting progress due to inflammatory response. Or it could be inflammation or fibrosis both together. or it could be due to comorbid conditions. It could be due to pulmonary hypertension, commonly we see in our population, or it could be cardiac comorbidities. Most of the patients do have, they're sharing all the same cardiac risk factors. And also it could be due to simple as deconditioning. So it's very important to identify the context of progression, whether this progression is in the fibrotic element of the lung disease, and whether there's an ongoing disease-specific inflammation. You have to exclude all the other arms, the comorbidities as well as the infections and the acute exacerbations. And what is the optimum treatment? The optimum treatment will depend on the setting. For example, whatever the optimum treatment, that we should ideally have an initial diagnosis, a confirmed or confident diagnosis. And also we have to assess the longitudinal behavior or the initial response to treatment, and also the patient preferences. So we have to adhere to this simple protocol, get a detailed history. There may be first round of history, there may be second round of history, there may be third round of history. So history is a dynamic process. We take a detailed history and we do the investigations, and we have some suggestions about the differential diagnosis from the investigation, and we go back to the patient and ask specific questions. So that's why second cycle of history, again third cycle. This approach is very important. And then do the HRCT and identify the pattern and discuss all this in a MDT, where the experts in radiology or rheumatology sometimes and respiratory physicians are get together and come into a consensus diagnosis, whether we can come to a confident diagnosis, or whether we are working on a diagnosis. So this is very important before we discuss about the progressive pulmonary fibrosis, to think about a definite or confident diagnosis at the beginning of the disease. And next, we should understand the pathophysiology of fibrosis. Professor Wells is here. I mean, he will discuss further, but fibrosis is a tsunami of events. There are multiple pathways. Still, there are some pathways that not being identified. The perfidone and nintedanib, which I'll discuss later, are acting on many pathways. So if you summarize the pathophysiology, there are two phases at least in this process. The initial or early phase. In IPF patients who are elderly population, and when they have genetic susceptibility, when they have epithelial injury, as you can see here, epithelial injury, it leads straight away for the fibrosis. And then other cases, in case of HP, when there's a persistent antigen exposure, lead to chronic inflammation and lead to fibroblast formation and fibrotic process. And then in autoimmunity, in CTDs, there's autoimmune response leading to chronic inflammation. In sarcoidosis, granulomas leading to chronic inflammation and fibrosis. But we should identify, this is the early phase. Whatever the initial phase that we are dealing with, when you come to the late phase, when the patients develop some sort of fibrosis, it is a self-perpetuating process. The fibrosis itself triggers fibrosis. This is your late phase. Whatever the insult, it could be IPF, it could be PPF, or what, apart from IPF, whatever the insult, when you come to the fibrotic process, it is a self-perpetuating process. So that's why we need two treatments. If it is IPF, a single pathway of antifibrotics. If it is other inflammatory disorders, we have to think about the extent of inflammation, which is starting this fibrosis, and then consider antifibrotics to tackle this pathway. This is the pathophysiology behind, or the science behind this dual treatment of immunosuppression or immunomodulation with antifibrotic. And if you summarize, there are overlapping mechanisms of disease progression. In IPF, there's hardly any inflammation, insult, injury, and then go into fibrosis. In CTD-ILD, there is inflammation leading to fibrosis. In HP, there is exposure, inflammation, and leading to fibrosis. So the optimal management is not only the immunomodulation. In case of HP, removal of the antigens from the environment, that is also optimal management. So you don't have to do anything if the patient has acute HP, just remove the antigen, that's it. That is also optimal management. No point of offering antifibrotics to these patients if the patient is continuously exposed to the antigens. So the progression of the fibrosis has to be demonstrated either radiologically or histologically. I mean, we are not going to do any biopsies to confirm the fibrosis or confirm the progression. It's less likely. there are 4 parameters that we should look into the CT scans to look at the fibrosis. But yesterday, Dr. Jankari is one of the excellent radiologists. He discussed in detail about this fibrosis changes. But I'll briefly go through. There are 4 signs that you look into: the honeycombing and traction bronchiectasis, fissural retraction or volume loss, and then the coarse reticulations. So this is the first patient who had the CT scan at the initial stage. There's evidence of ground glass opacities, and you can see that there's no definite amount of traction bronchiectasis or any other features of fibrosis here. And then the second CT scan of the same patient, as you can see, there are areas of traction bronchiectasis and some coarse reticulation. So there's some evidence of fibrosis. And the second CT scan, lung bases, there are early cyst-like lesions which could represent the honeycombing. And then the last CT scan, as you can see here, the patient is definitely developed some honeycombing. This is the radiological evidence of progression in fibrosis that we should demonstrate when you consider antifibrotic treatment. And when to offer and what to offer. So it's very important. What are our aims and objectives? We have 2 objectives of treating these patients. One is to expand their quantity of life, and the second is to improve the quality of life. No point of improving the quantity of life if they do have a quality. So therefore, always think whether we are going to extend a life with quality rather than quantity alone. So first, we should ask the question, what is the context of progression? The same diagram, whether it is due to the inflammatory response, whether it is due to the comorbid conditions, whether it's a pure progressive pulmonary fibrosis. And then what is the likelihood of benefit from immunosuppression if the disease is due to disease-specific inflammation. In that case, a simple diagram that it is published by Dr. Sujit Rajan, one of the ILD expert in India. So basically, and Professor Wells is one of the co-authors in this paper. So if the patient has a UIP pattern, if the patient has older age, and also if the patient has recurrent infections, and then absence of any clinical and physiological improvement before with immunosuppression, they are less likely to get benefit from immunomodulation. Whereas if the patients are young, if there's an OP pattern, an SIV pattern, if there's any myositis involvement, or if there are systemic features which can improve with immunosuppression, and then if there's any previous objective evidence of improvement with immunomodulation, in that group have increased likelihood of developing benefits from immunosuppressants or immunomodulation. Then what is the likelihood of benefiting from antifibrotics? If you consider the interstitial lung disease, as you know, our prototype is IPF here, but rest of the interstitial lung disease, predominantly the unclassifiable ILD, and then the CTD ILDs, there's about 30 to 40% of the population of these ILDs can progress to fibrosis irrespective of the optimum treatment. If we consider the antifibrotics, the first one is a nintedanib, which is a multiple tyrosine kinase inhibitor. Across all the fibrotic lung diseases, including IPF, as you can see, impulse 1 and 2 in IPF, senses in systemic sclerosis, inbuilt in all the other progressive pulmonary fibrosis, there is no doubt there's a benefit. But especially if there's a UIP pattern in the lung diseases, the benefit would be marginally better than the other patterns. But across all fibrotic lung diseases, including IPF, we know the nintedanib works very well. And pirfenidone, this actually is a phase 2 study, and this is due to the designing issues. Actually, they could not achieve the primary endpoint of this study. However, all the secondary endpoints shows that there's a positive signal for pirfenidone, which we can consider in fibrotic lung disease. But if I summarize, in IPF, nintedanib and pirfenidone has a comparable efficacy, which has been approved. And in non-IPF, that is PPF, nintedanib has been approved because we have strong evidence, but pirfenidone, the evidence is emerging. But in our part of the world, in the absence of nintedanib in our setup, I think there's no contraindication, or we can rationalize the use of pirfenidone in our setup in the absence of nintedanib. I'm sure Professor Wells will agree with me. Next, what is the likelihood of benefiting from lung transplantation? That has to be assessed at the earliest onset, because the lung transplantation is not a cure for these patients. We don't have the transplant options here, but at least we should mention that, okay, we don't have that option, but these are the possibilities that we can offer. Even in the other part of the world, if you offer the lung transplantation, we know that fibrotic lung diseases, they do poor. Their survival is only 40% at 5 years. So that is the worst surviving transplant indication in the other part of the world, especially in UK. So there are many mechanisms that we don't know at the moment, involved in various studies, that we are going to look into the mechanisms of poor prognosis in fibrotic lung disease, but is apart from this topic. But a transplant is not the option. Therefore, early identification and early treatment is the option. And the last but not least, it is very important to identify what are the patient's expectation, wishes, and preferences of their life. No point, all these antifibrotics, they are very toxin medication. There are significant side effects. All the immunomodulatory therapies, there are a lot of significant side effects. And some of the antifibrotics, actually, they are not affecting at all for their symptoms. So it's very important to discuss, come to this dialogue, what are their expectations, what are their wishes. So therefore, always in ILD, please approach this 360 approach for ILD. That we are mainly concerned about this antifibrotic immunomodulatory therapy, but that is least important for the patient. We have to consider the supportive measures, particularly supplementary oxygen, pulmonary rehabilitation, psychological support, and then symptom control, utmost important, because none of the antifibrotics would benefit the symptoms at all. They are dyspnea, fatigue, cough, anxiety, and depression. And then the end-of-life care. Have advanced life decisions and discuss about their end-of-life conversations and treatment options and palliative therapy in the early, at the earliest stage, and then express what options we do have. And this is all for the talk today. Thank you so much, and I'll be delighted to take any questions if you have.
I suggest that we have questions at the end of the session. So I invite my co-chair to introduce the next speaker.
Thank you, Amira, for that wonderful lecture. So our next speaker is Dr. Manal Rahman, consultant pulmonologist from Banglabandhu Sheikh Mujib Medical University Hospital, Bangladesh. He will be talking to us regarding overview of rare interstitial lung diseases. Over to you, Dr. Manal Rahman.
Good morning, and thank you for that very kind introduction. I'm actually a very early career pulmonologist, and I'm both literally and figuratively, I would say, dwarfed by the giant talent that has preceded me and will follow. But I'm going to give a very brief review of some rare ILDs, some that we have faced in our practice. So this is basically the classification of non-IPF ILDs, and among these, I will be talking about PPFE, LCH, PAP, LAM, and some others here, as you can see. So beginning with PPFE, because this is the most common presentation that we are seeing in Bangladesh. So it is a rare form of interstitial pneumonia, and it differs from the other interstitial pneumonias by the fact that it is more characterized by deposition of elastin rather than simple collagen. So here it mainly involves the upper lobes bilaterally, and there is thickening of the visceral pleura as well as fibrosis of the underlying lung parenchyma. But as you can see here, this is the normal alveolus, and these purple markings here denote elastin deposition, and the entire alveolus is obliterated by collagen fibers with elastin in the septa. So this is intraalveolar fibroelastosis, the characteristic histopathological finding of PPFE, which is progressive, which is pleuroparenchymal fibroelastosis. So this is actually occurring as a result of aberrant healing due to a particular repetitive or subacute lung injury. And this lung injury may be idiopathic with no known cause, but it can also occur secondary to transplants, particularly lung transplants or bone marrow hematopoietic stem cell transplants, in which case there may be a latency of 10 years following the transplants. And it may also occur in association with other fibrotic DPLDs, particularly IPF or even hypersensitivity pneumonitis, and with some environmental exposures and other autoimmune diseases, including rheumatoid arthritis and scleroderma. But what we see more in our context is infection. So this could be NTM, it could be aspergillus, but can it also be MTB? Literature does not mention MTB, mycobacterium tuberculosis, but in Bangladesh, most of the patients who present with PPFE have had a preceding either diagnosed case or history of TB, or have been exposed to a person who has TB, and Bangladesh has a very high prevalence of TB. So that's a query here. And with the presentation, as you can see, it has a bimodal presentation. There is a predominance in the early ages of around 21 to 30. This is mainly familial causes, and it also has another presentation at around the 3rd and 4th decades of life. So this is different from IPF, whereas IPF presents later in life, and it has no other gender predominance, no association with smoking, and patients present with the typical features of cough and progressive exertional dyspnea, but in addition, they have weight loss, which is again another characteristic, and they also have recurrent pneumothorax, which may present with pleuritic chest pain. And on examination, there is very distinct flattening of the chest, mainly of the upper lobes, platithorax, where the anteroposterior diameter is reduced. And in very advanced cases, they may even be hollowing out of the suprasternal notch, as you can see here. So when we do a chest X-ray, a chest X would reflect these findings. We would find upper lobe fibrosis, volume loss, and the earlier sign would be a hilar elevation bilaterally, and a lateral chest X-ray would also show a reduction in the anteroposterior diameter. And this is important because this has an effect on the quality of life, the function, and also the disease progression. In the late stages, yes, there may be advanced fibrosis, not limited only to the upper lobes, but involving the entire chest. And HRCT findings are what is diagnostic of this condition. As you can see here, there's upper lobe volume loss, traction bronchiectasis, and also subpleural consolidations. And as a whole, there's a loss of architecture, and this may be accompanied by pneumothoraces, which may be bilateral. It is also important when you evaluate the HRCT to look for secondary causes of PPFE, whether that is rheumatoid arthritis, whether systemic sclerosis, or any other infections. So pulmonary function testing, well, this is a DPLD, so the test would reflect restrictive ventilatory defect, but the difference here is that the RV-TLC ratio is increased in this case. This may be because of air trapping, but this is characteristic of PPFE. And the arterial PCO2, we would expect this to be type 1 failure. Initially it is, but in advanced cases, because there is restriction of the chest wall during ventilation, so it would be increased in advanced cases. So this would help us label a patient with PPFE, but that is obviously not the end. We would have to look for any underlying causes. Again, in the Bangladeshi context, it's infection that we are most concerned about, particularly aspergillus and TB, NTM infections. And also we'd obviously have to check for all of the other causes, not only from investigations, but also a very thorough history. So the diagnostic criteria are definite, if you want to be very specific about it, definite HRCT findings combined with definite histopathological findings, but obviously HRCT findings would take precedence because histopathological findings may be difficult to come by, as biopsy can result in pneumothorax. It has a high risk of pneumothorax, which may end up with a prolonged air leak and is much harder to treat. So histopathological diagnostic criteria, I've shown it visually before. There's upper lobe fibrosis with subpleural intraalveolar fibroelastosis, just a schematic picture as you've seen here. The figure A shows the histopathology on a routine staining, on HE staining, but when we use specific elastin stain, you can see that the elastin deposition highlights up. So moving on to the HRCT criteria, so definite, this also is again ranked as definite, consistent, and inconsistent, but now a study has shown that we can actually follow only HRCT criteria for diagnosis, where we have upper lobe pleural thickening with subpleural fibrosis, minimal lower lobe involvement, and, in addition, evidence of radiological progression. This is by seeing an increase in upper lobe consolidation or a reduction in upper lobe volume by serial CT scan volumetry and exclusion of other causes. So a Japanese study showed that these HRCT criteria, these three conditions, can be used in place of HRCT and biopsy for diagnosis of PPFE. So this would be sufficient. And there's a radiological differential, apical cap. And as you know, apical cap is, it's not a pathological condition. It may be present in many elderly patients. So it is the absence of radiological progression which would differentiate your apical cap from PPFE. So PPFE is actually, idiopathic PPFE is progressive, and secondary PPFE, it may be progressive too, as we've heard from the previous speaker, that fibrosis begets fibrosis. However, there's not much data on it yet, and we are running a PPFE registry in Bangladesh right now, and we hope to be able to come up with an answer to that in the next year or so. So because of the different causes of PPFE, the data is very heterogeneous, and it shows a mean survival of 2 to 11 years from diagnosis, but there is a rapid progressive phenotype which can be identified with a median survival of less than 5 years, and there's some risk factors here. I'll be going into in more detail later. One of it is if it is idiopathic or secondary to lung transplantation or genetic causes. And as we know, complications, they can be pneumothorax, recurrent pneumothoraces, which are difficult to treat, even pneumomediastinum, as a matter of fact, recurrent respiratory tract infections, and in late stages, it can end up with hypercapnic respiratory failure. So here, this was a study which was to develop a tool to identify the prognosis of patients with primarily idiopathic pleurochimal fibroelastosis. And as you can see, the variables that they identified were independently associated with prognosis were FEV1, a history of pneumothorax, ILD extending in the lower lobes, which could be any other type of ILD, particularly UIP pattern, KL6 more than 550 units per liter, and based on this there was a score, and based on the score a grade of 1, 2, 3 was given. So if there's grade 1, the survival was highest with a 5-year survival of 88%. In stage 2, the survival was 45, and in stage 3, even poorer than that, it's 24%. So we already have a score, the GAP score for DPLD. So why was that not used? As a matter of fact, this study compared the GAP score and the PPFE prognosis score, and it showed that the GAP score, while it was sensitive for more, the GAP score did not perform so well in more severe cases, such as grade 2 and grade 3. It almost could not differentiate between them. It was not very sensitive in those patients. So this is the area in which PPFE prognosis score would work better. So I'm moving on, a very brief overview of what pulmonary alveolar proteinosis is. As our previous DPLD, the alveoli were obliterated by fibrosis, and here the alveoli are obliterated by a normal surfactant, which is not cleared away by the macrophages. This could either be due to a macrophage surfactant dysfunction itself, or it could be due to the inability of the macrophages to clear up the surfactant. This could be primary, due to the production of anti-GM CSF antibodies, granulocyte monocyte colony-stimulating factor antibodies, and we know that this is essential for macrophage activation, and the presence of this would lead to accumulation, or there could be some secondary causes. This leads to a reduction in the number of the macrophages or the function of the macrophages, and congenital as well due to impaired production or abnormal production of surfactant. So this is what happens normally. In a normal, healthy individual, the surfactant which is produced by the type 2 pneumocytes is then taken up by the macrophages and cleared away, and this requires the presence of GM-CSF. However, in cases of autoimmune pulmonary alveolar proteinosis, which make up 90% of cases, the presence of antibodies prevent binding of the GSF to the receptors on the macrophage. So these are the secondary causes of pulmonary alveolar proteinosis. However, they make up less than 10% of the causes. And among these, the 75% of cases are due to hematological malignancies, particularly myelodysplastic syndromes, lymphoproliferative disorders, and leukemias. So here there's a male predominance, and usually the patients present in the 3rd to 5th decade of life, younger in cases of congenital pulmonary alveolar proteinosis or genetic alveolar proteinosis. And here there's a very wide range in case of congenital PAP, where the patients can present any time from the first few days of life up to adulthood, so the presentation is very heterogeneous. But in other cases, there's an insidious onset of cough and exertional dyspnea. And here, there's another characteristic feature, which is fever. So patients may present with fever, recurrent fever of unknown origin, or they may first present as a case of unresolving pneumonia, which has undergone a lot of investigations, but with no result. And in 1/3 of cases, patients may be completely asymptomatic and detected just on a routine scan. So examination may be completely normal. In some cases, there may be crepitations, and clubbing is not a very significant finding. So diagnosis is a combination of 3 steps. The first is typical HRCT findings, typical ball fluid, and then supportive other tests. So in HRCT, we would find in primary, and the most common type of autoimmune pulmonary alveolar proteinosis, we would find ground glass opacities, which are geographically diffusely distributed, and also superimposed on that would be interlobular septal thickening. And that is what we know as crazy paving. Fibrosis is very rare, but in secondary PAP, there is diffuse ground glass opacity. There's no geographical distribution, and there's no crazy paving. So that might be confused with other ILDs, like particularly NSIP. Certain features, if present, like nodules or lymphadenopathy or effusion, would refute a diagnosis of PAP, and we'd have to look at other causes of crazy paving. So an HRCT would give us a suspicion, and we would have to perform a ball fluid analysis by bronchoscopy. If the ball fluid is milky or opalescent, that would confirm our diagnosis, and we'd further confirm it with light microscopy, where we would find lots of cellular debris, acellular globules, which are basophilic, and characteristic macrophages filled with oily material or foamy macrophages. And to confirm the diagnosis of autoimmune PAP, we would require serum anti-GM-CSF antibody, which is elevated to more than 19 micrograms per ml. This has a sensitivity and a specificity approaching 100% when associated with the HRCT findings. However, it has very limited availability. It's not even available in Bangladesh. And for congenital PAP syndromes, the serum GM-CSF level may be elevated in some of them. LDH is non-specifically elevated, so it's not very helpful in our diagnosis. And PFT, yes, we do pulmonary function tests mainly to assess when to start treatment and look at the progression response of treatment. So the patient may come with a chest X-ray like this, and in most cases, we would think that this is a case of pulmonary edema, and patients may also have features of that, but patients would not be as acutely breathless as a patient with LVF. So it's when we do the HRCT, this is the characteristic geographic crazy paving appearance, where areas of crazy paving are interspersed with areas of normal lung, and it is very sharply demarcated. So there are some radiological differentials of crazy paving, and this particular HRCT was taken from a COVID-19 patient. So obviously not all crazy paving is PAP. So in ball fluid, this is what the ball fluid would look like. And under the light microscope, you can see that there are many extracellular globules. They have the purple magenta-ish staining, as well as some macrophages. So basically, I'm going to skip this slide. We've talked about the 3 steps already of PAP diagnosis. And now looking at the clinical course, in 90% of cases, it is autoimmune. In most cases, it may be stable or unremitting, but in some cases, there is progressive deterioration, and in another fraction, around 7 to 10%, there may even be spontaneous resolution because it's an underlying autoimmune disorder after all. But in secondary PAP, the prognosis depends on the underlying disease, and in most cases, there is worsening due to the underlying disease itself, not PAP. And genetic, well, there's still insufficient data. For autoimmune PAP, the 5-year survival without treatment is quite high, as you can see, it's 85%, and when combined with whole lung lavage, it's 94%. So the complications we need to remember are these patients are very susceptible to opportunistic infections, because after all, it is a macrophage function which is being impaired. So they may present with recurrent respiratory tract infections of unusual causes. Let's not forget that they may be Aspergillus nocardia, even coccidioidomycosis and so on. So in brief, if the patient is asymptomatic at presentation, has normal or mildly impaired pulmonary function tests, is not hypoxic at rest or at exercise, all we would need to do is give supportive management with vaccination, smoking cessation, and so on, and monitor the patient 3 to 6 monthly. If there's an underlying cause that can be identified, we would need to manage that. But during monitoring or even at presentation, if the patient becomes symptomatic with further deterioration in pulmonary function testing, or if the patient develops functional impairment, we would have to exclude the infection first as a cause, and then when we are convinced that this is due to progression of the disease, we would need to refer the patient for definitive management, which is whole lung lavage, and in some centers, if available, and if the patient is autoimmune PAP, we could consider supplementation by GM-CSF, either by the nebulized form or by the subcutaneous route. If there is no response, we can consider a repeat whole lung lavage or some other experimental therapies such as rituximab or plasmapheresis, even lung transplantation. And the question does arise that this is an autoimmune condition, why are we not using corticosteroids? Well, corticosteroids have been used in several trials, and there has been shown to be no benefit. So that is not an option in this case. The whole lung lavage, it's not as simple as it sounds. It's actually a procedure done under complete general anesthesia, which will require double lung ventilation and filling up one of the lungs with fluid and small aliquots. And there is no, as yet, there is no general consensus on exactly how it should be done. Different centers follow different protocols, as a result of which the outcomes are also very variable. But overall, there is a 95% response, at least initially. By response, we mean response in symptoms as well as radiology, but there is an appreciable relapse rate, as you can see, 33 to 60%, and there are also appreciable complications. So this is something that obviously has to be done in a center with plenty of expertise in this case. Now we move on to some cystic lung diseases. I think that just this slide should tell you all there is to know. So we're going to be looking at LAM, PLCH, LIP, and BHD in a very brief. So LAM is, it's actually DPLD, but it is a metastatic neoplasm where there's accumulation of abnormal LAM cells in different organs of the body, particularly the lung and the lymphatics, and it has two forms. It can occur sporadically or in association with tuberous sclerosis, where there is a loss of function mutation in the tumor suppressor gene TSC1 and TSC2. And this suppression of the tumor suppressor gene leads to overworking of the mTOR complex, and this in turn inhibits cell apoptosis and causes cell overgrowth. So it's very essential that we delineate what the main cell signaling pathways are, because based on this we can develop targeted therapies later on. So the typical presentation is occurrence of spontaneous pneumothorax or bilateral pneumothorax or recurrent pneumothorax in a young reproductive age female, usually presenting in the 3rd or 4th decade of life. And these patients would show a worsening of their symptoms around the time of menstruation or pregnancy or while taking hormonal contraceptives. Okay, so I will just skip this and move on to the diagnosis of LAM, where we have to show HRCT chest and abdomen findings and raise vascular endothelial growth factor and exclusion of other cystic lung mimics. Okay, further on, there are a few things that I'd like to tell about the treatment of LAM. In this case, pneumothorax, after the initial presentation of pneumothorax, the patient must undergo pleurodesis, and this has to be done by VATS mechanically, not chemical pleurodesis. And we also have to counsel the patient regarding pregnancy to be avoided if possible. Another important thing is avoid vaccinations in patients with LAM. And the main treatment here is sirolimus, which is an mTOR inhibitor. And another case I would just like to show before I end up with this is as I was preparing for this presentation, we had this case admitted under us, a 34-year-old lady who presented with shortness of breath for 3 years, which was worse for 2 weeks, and a history of prolonged bleeding since childhood following minor cuts. She had a very pale complexion compared to one of her siblings, but the other 2 siblings and her mother also had her similar complexion. And on examination, I don't know whether the video is being played here. She had horizontal nystagmus and bilateral fine inspiratory creps, and she was hypoxic at rest. So a combination of these features would lead to a diagnosis of Hermansky-Pudlak syndrome. We have not diagnosed her as yet, but this is our suspicion based on oculocutaneous albinism, bleeding, which is due to platelet dysfunction, horizontal nystagmus, and pulmonary fibrosis. So in conclusion, some of the rare DPLDs, they may be more common than thought, but they may remain undiagnosed, and a complete history, including history of environmental exposures, family history, and a thorough clinical examination with MDT are indispensable for diagnosis of rare DPLDs. Thank you very much for your time.
Thank you, Dr. Manil Rahman, for that excellent presentation. We'll be moving to the next lecture now.
So, next speaker is Professor Thol Wells, Professor of Respiratory Medicine at the Royal Brompton Hospital and Imperial College London. Professor Wells is a world authority on ILD, especially sarcoidosis. So he will speak to us on practical approach in the management of sarcoidosis.
Thank you very much. I really feel I should start by addressing your opening comment that many clinicians find ILD to be a nightmare. Now, I debated against Peter Barnes some years ago. Large audience, COPD versus ILD. Peter, in his part of the debate, drew many similarities between COPD and ILD. All I could say in response was, that was very true, but there was one essential difference. Interstitial lung disease is interesting. He enjoyed that, I hope you do. But it's right that if you're threatened by uncertainty and you don't like it, don't go into interstitial lung disease. If you enjoy uncertainty, embrace it, because you can be creative. You can make things up as you go along. And you fit that with the data. And nowhere is this more true than in the management of sarcoidosis, which I have to say has been something of a mess over the decades. There are people who treat all sarcoid patients. There are people who have in the past treated virtually no sarcoid patients. Patients don't like this. If they don't understand what you're trying to do, they don't see the logic, they will vote with their feet. And so what I worked out conceptually 20 years ago, which is now evolved to underpin the recent guideline, is how do you make this logical? Logical to patients, and I worked this out by talking to patients and actually polling them effectively on how they felt about what I was saying. When should treatment be instituted? Because there's a chaos in the literature. You will find these long lists of individual symptoms that might need treatment, or in the lungs, there will be a bullet point about lung function, there will be a bullet point about change in imaging, there will be a bullet point about cough. So indications for treatment, you might have 40 indications, but you don't have 40 logics, and if you don't present the logic, you might as well give up. So, logic. And from what was, I think, a brilliant first talk, we got this message for PPF. What outcomes do patients want from a doctor And I've yet to find a patient who could give me a third goal. They want to live longer and they want to feel better. So immediately we have a logic. There are just two reasons to treat sarcoidosis. If there is danger, you are treating people in order to make them live longer, or danger may be permanent disability rather than death, so you are treating them to prevent permanent disability from major organ involvement, or you're treating unacceptable loss of quality of life. If you cannot tick one of these two boxes, then don't actually treat the patient. If you don't, I fall back on mycotherapy, that if you don't have a reason to treat, you watch. And you watch closely, cat-like observation, a cat gazing at a mouse hole ready to pounce. So Voltaire, in that scenario, the role of the doctor is to amuse the patient while nature takes its course. So that being so, how should we address management with individual patients? And I'm giving you something I worked out talking to patients before I dared to present it, first nationally and then internationally. So you lay on the line that you're actually sorting out whether there's danger. You want to know if the patient feels rotten, that you should be looking at something for that reason. These are not synonymous. You can feel well but have growing danger from a major organ involvement, or you can feel appallingly compromised on quality of life grounds, but with nothing happening that threatens your life expectancy. If you don't spell this out, you can't have a discussion on what you're trying to achieve and how you're trying to achieve it. So would you mind moving away from the slides so that I can see it? Thank you. I can't see it so very well here. So how do you apply this in practice? Well, at the start, when you first meet a patient, you make clear what your job is initially. You're going to find danger if it exists. You're going to screen for that. And if there's danger, your duty is to make treatment recommendations based on medical expertise. But you also agree on what the job of the patient is. While you're getting the test results, they are thinking day by day. Often they know the answer in the first 5 minutes, actually, but sometimes they don't. So just think about how sarcoidosis, sorry, again, could you please not block the slide? Thank you. If you could then think about how sarcoidosis is actually affecting your life. Is it damaging your life? And based on this, what would you feel about choosing to accept treatment side effects? And you'll talk about those, and we'll come to that. But what would you say about that? Actually, are you quite clear that you would rather not look at therapy on quality of life grounds? And people very often take strong views, actually, that they don't want treatment on quality of life grounds. Now, you've got to get rid of the concept of sarcoid as a benign disease, and this is a common canard. 6 to 7% of sarcoid patients, and this recurs, have shortening of life expectancy due to sarcoid, but this is concentrated in the 30% of sarcoid patients with major organ involvement that isn't transitory. So 6 to 7 out of 30, if you've got major organ involvement, you're potentially talking about a mortality, it may be 15, 20, 25%. It's certainly not trivial. These patients don't have a benign disease. But sarcoid ascribable deaths that you see in the literature are not the whole story, and I don't have time to take you through a huge amount of literature on this. But comorbidities are terribly common in sarcoid that are related to steroids and immunosuppressive drugs. And there's a long list, and people with sarcoid commonly die of these comorbidities. If you die of diabetes or cardiac disease because of long-term high-dose steroid, you have actually died of sarcoid. You've died of sarcoid therapy, of treatments that you would not have had but for sarcoid. So sarcoid mortality is more than just death directly due to the disease. And so we are walking a tightrope in treating for danger. If you don't treat dangerous disease, you'll get mortality from sarcoid. If you overtreat disease, you will get mortality due to sarcoid therapy. Therefore, we've got to be very, very clear as to what we mean by dangerous disease, and what we don't mean is scadding staging. It's like gap staging. These tests are great for large cohorts. They're moderately useless for individual patients. You know, in gap staging outside sarcoid, 1 or 2% change in FVC changes your gap stage. I don't believe you get a radically different survival if your FVC is 76 as opposed to 75%. And for sarcoid with scadding staging, cohort statements are all very well, but in individuals, not very reliable, and we see this in this sort of study. This is stage 4 sarcoid, a French study, I believe. Stage 4 sarcoid versus general population. Yes, there's a difference, but it isn't a radical difference. And we can do better than that. And all I'm going to tell you here is watch this space. Simple lung function staging, 2 cohorts here. 1,200 patients at the Brompton, roughly the same at St. Antonius in Utrecht in Holland, further validation that is similar in Paris. And I'm not quite ready to release the exact thresholds, but based on a DLCO threshold, and if you're marginal above the threshold, an FVC threshold, these are the separations you see in survival in sarcoid, trumping chest X-ray. And you can see that on the one hand, if you're above these thresholds, you survive like the general population. But once you cross a certain severity, the train has left the station, and even with best treatment, your mortality goes up tenfold. Now, risk stratification means you have to treat before the train has left the station. You shouldn't be waiting till you've got, even with optimal treatment, these sorts of outcomes. And just in passing, when you apply this simple lung function system, it gives you exactly the same separations in those patients with stage 4 disease and those patients that don't have stage 4 disease. So it trumps chest X-ray, although in these cohorts, stage 4 still had a worse survival than the rest of the patients. So all I'm going to say to you is that we now know in the lungs, you've got to get worried if the gas transfer is less than 55%. The key threshold is 40%, and that if the FVC is less than 65%, the key threshold is 55%, but you shouldn't be waiting till the lung function reaches that point. And you're also worried if disease is short in duration. We had a case yesterday, FVC 69%, but actually only 6 months, so getting to that level quite quickly. You're worried about ongoing progression, and you look at the CT phenotype and you make a judgment. Is disease almost certainly reversible? You might choose to treat it if you're approaching a boundary. You might also observe knowing you can recover lost ground. is it a combination of nodules and possibly the beginnings of progressive massive fibrosis? So you might be a bit more worried about observation. And certainly if you're approaching thresholds with disease like this that is irreversible, you will want to get in and treat quite protectively at that point. And if dyspnea is out of sync with especially imaging, you get worried about cardiac sarcoid, another danger, you look for that. You get worried about the development of early pulmonary hypertension, you look for that. So you're going through dangers, and these are the danger patterns that you screen for. And you usually get told by the patient that there's a neurological issue. So there isn't really a screening test there. But these are the dangers which might drive therapy. And when you have danger, I reiterate, you don't necessarily have correlation with symptoms. It's medical expertise that should drive management. And what you should not do is to undertreat initially in mistaken kindness. It's actually better to control disease activity rigorously first, and then maintain control, often going down to a much lower dose, but establishing that you have, and then you go on to establish the minimum required dose. Now, very often you want to decide at the outset whether you think in that patient you're going to manage to maintain control on monotherapy. And often you have a very good idea about this, and if it's obvious that you are highly likely to need more than low-dose steroid in the longer term, and I'm not talking about initial therapy, you can pulse patients if you're worried, you can give them high-dose steroid, I'm talking about down the line, it's obvious to you that low-dose steroid is unlikely to be enough. That's when you introduce a second-line agent at the outset. Now, I think it's just worth saying that in your initial dose, it's all context-driven. Bad cardiac sarcoid with intense inflammation on a PET, you're going to go for high-dose steroid most often. We don't have definitive data, it must be said. We tend to pulse and then go quickly down to 20 milligrams daily, and at follow-up PET, this does a very good job. High doses take control, and then doses that would not take control can maintain control. But this is a very nice study in the lesser extreme scenarios. I think about the best work done in recent years, which simply shows very clearly, Dr. Duria at Chandigarh, that actually, if you're not in an extreme scenario, a more civilized dose of prednisolone, 20 milligrams daily, does absolutely as well as the traditional punitive regimens of 40 milligrams daily. And that's the one bit of data I'm going to present. If you want more data, go to this document, but I can't summarize this all today. It spells out first line, second line, third line agents. And this is where mostly you have dangerous disease. Now, second line agents, you're really talking about the nastiness of therapies. And in the longer term, the nastiest therapy is probably high-dose steroid. The nicest is low-dose steroid on average. The steroid-sparing agents are somewhere in between. So what you're really asking is whether the long-term needs of the patient are met by, or are likely to be met by, a dose of steroid of this sort of magnitude. If the answer is no, get the second line agent in there, and it may have additive benefits apart from being steroid sensitive. Just a footnote, hydroxychloroquine is a weak drug on average. Some patients find it far more effective. It probably equates to 2.5 to 5 milligrams of prednisolone daily on average as a non-steroid drug. But that may be a critical contribution which allows the dose of steroid to come down to, say, 5 milligrams daily, or may even replace steroid in some patients. Practical points. Now, let me move to quality of life. I can't have a lot longer before the fatal bell rings. It must be imminent, I think. So, quality of life, a radically different approach. It's poorly explained in medical texts. In the conversation, there's only one world expert on the patient's quality of life, and that's the patient. I can't do a blood test and declare there's 17.312 units of fatigue. So really, to make management work, you must enlist the patient and reach a shared decision, and this is not an abrogation of medical responsibility. Some patients won't like that. They'll say, you're the doctor. You've just got to say, if you want me to be God, I'll judge this. But I think the decision would be a better one if you took a view. Now, if you don't do this, and you give the patient steroid therapy to make them feel better, and they feel worse, they'll vote with their feet at that point. They'll see this as a failure. If you spell out that you're teasing out an approach, you're balancing side effects against benefits and quality of life, you might at first get this wrong, but actually you're inviting the patient often to experiment with doses of low-dose steroid, titrate what you use against quality of life, against side effects, and find the level of treatment that suits you. So I make 15 different deals with 50 different patients. The starting dose is negotiable. Actually, what you choose to use at the start is, some patients have steroid phobias, you negotiate methotrexate monotherapy. Now, I think I'm almost there. I'm not going to do the last slides, however, in 5 seconds per slide. So really what you're doing is creating a symptom package that requires intervention. You're amalgamating often pulmonary and non-pulmonary symptoms. And I've highlighted fatigue because you have to handle that separately, because it often doesn't respond to traditional sarcoid therapies, but there is not time to go into that. And so I think I can draw quickly to 2 slides to finish with. Fatigue really is a major issue. Now, I routinely ask patients, if you could lose one symptom when they first meet me, what symptom would that be? And once patients understand that it's not shameful to admit to fatigue, it's not all in their minds, it's part of sarcoid, more than half the time it's fatigue. You will think it's lung symptoms, they will tell you it's fatigue. And you've got to worry that sleep disturbance, if there's pain in the joints from sarcoid or there's obstructive sleep apnea because of steroids, are going to add to fatigue. And the normal human reaction to having sarcoid is not to be ecstatically happy, but to be unhappy. And if you have a reactive depression, that's going to drain your energy also. So you have to talk through these things with the patient. And I can't go further in discussing this. Maybe it will come up in discussion. I will move to the summary. Big picture. Patients understand this. Is the danger? Is there unacceptable loss of quality of life? What you do, how you do it, what you introduce, what dose, is entirely geared to this. And patients understand this, they buy into it, and you have a partnership. Risk stratification is crucial, and I believe strongly that laying out the power grids at the start, a sharp separation between, I'm afraid I've got to twist your arm about this in dangerous disease, and shared decision making if you're talking about quality of life, makes the whole interaction between doctor and patient far more effective. And on this note, the bell sounded a bell or two ago, so I will stop.
you, Professor Wells, for that very practical lecture on sarcoidosis.
It's my pleasant task to introduce the next speaker, our last speaker today, Dr. Mohammed Ismail, who is the head Department of Respiratory Medicine, Indira Gandhi Memorial Hospital, Male. He will be talking to us regarding hypersensitivity pneumonitis and update on new guidelines.
Very good morning to today's session. The topic for today's session is hypersensitivity pneumonitis and update on the new guidelines. So today I'll be talking about hypersensitivity pneumonitis. So hypersensitivity pneumonitis is a complex form of interstitial lung disease characterized by immune-mediated inflammation following an inciting agent exposure in a susceptible individual. Chronic exposure leads to progression of inflammation with evolution of fibrotic response in the lung and progressive pulmonary fibrosis. It has two clinical phenotypes, that is fibrotic and non-fibrotic hypersensitivity pneumonitis. Knowledge of key features of this disease is critical in distinguishing hypersensitivity pneumonitis from other forms of idiopathic interstitial pneumonias, and which allows us to subsequently do appropriate interventions, including exposure avoidance and treatment. Historically, HP was classified as acute, subacute, or chronic based on the duration of symptoms. This classification is now regarded as of little clinical value due to difficulties in distinguishing these categories and their lack of association with outcomes. The latest guidelines propose categorizing as having non-fibrotic, which is purely inflammatory, or fibrotic, which has mixed inflammatory and fibrotic, or purely fibrotic pathology. The presence of fibrosis is a critical determinant of the progression of prognosis for the disease. If a culprit exposure has not been identified but have features typical of hypersensitivity pneumonitis, it is described as cryptogenic hypersensitivity pneumonitis, or HP, of undetermined cause. Recently, there have been two guidelines, which is from American Thoracic Society and Japanese Respiratory Society, and also in association with the Latin American Thoracic Society. And the other is from American College of Chest Physicians. These have established standardized diagnostic approaches to hypersensitivity pneumonitis. They provide similar diagnostic algorithms, establish clinical features and radiographic features and histopathologic features of the two clinical phenotypes. Both these guidelines emphasize the importance of classification of diagnosis of fibrotic HP or non-fibrotic HP, the distinction of which is made by the presence or absence of radiographic or histopathologic fibrosis. Before, time-based classification of acute and subacute or chronic was deemed very inferior by both of the working groups due to unreliable association with clinical outcomes. So the new approach was adapted to objectively define the disease presentation and to allow for more consistent association with the disease prognostication, as well as to better inform treatment decisions. The new approach was adapted to objectively define this presentation and to allow for more persistent association with disease prognostication, as well as to better inform treatment decisions. So the diagnosis of HP is often challenging given the heterogeneity in clinical presentation, in addition to overlap with other non-fibrotic and fibrotic interstitial lung diseases. And establishing a clinical profile may help inform pretest probability when distinguishing between the fibrotic interstitial lung diseases through an indeterminate clinical profile with overlapping features that may be compatible with both idiopathic pulmonary fibrosis and fibrotic hypersensitivity pneumonitis, such as a male of age more than 60 years of age, and if the person is a former smoker with a possible exposure, can make the distinction very difficult. As a result, misdiagnosis is not very infrequent, and as a portion of patients labeled as having IPF are often found to have fibrotic hypersensitive pneumonitis in different studies and case evaluations. Furthermore, causative agent antigen exposure is not identified in up to 60% of cases of HB, despite thorough evaluation of, with all the available modalities. Nonetheless, the index of suspicion for HB must remain high in clinicians' mind during the evaluation of interstitial lung disease. And this requires collaboration among expert pulmonologists, radiologists, and pathologists to optimize diagnostic accuracy. So the guidelines highlight three important clinical domains, that is, identify exposure and high-resolution CT scan imaging and bronchoalveolar large lymphocytes. Histopathologically, it should be limited. Histopathology should be limited to patients with low confidence of clinical diagnosis of hypersensitivity pneumonitis. For patients with low risk of complications with biopsy, so if the patients are at high risk of complications due to biopsy, then it is not indicated to undergo risky procedures such as lung biopsy. Initially, an antigen identification through comprehensive history should be the first step, and detailed environmental exposure history should be taken. And keep in mind the usual and unusual hypersensitivity pneumonitis inducers. Now, there have been several genes that have been associated with this disease. The best studies host factor actually are these the genes that a person is has predisposition to hypersensitivity pneumonitis. Variants in genes involved with innate and adaptive immunity may enable sensitization to inciting agents. So polymorphism in major histocompatibility complex class 2 and proteasomes, transporter proteins, and tissue inhibitors of matrix metalloproteinases have been also associated with this disease in several studies that has been shown in this slide. So the recent guidelines, both of the guidelines, they emphasize the important role of high-resolution CT scan in recognizing the distribution and pattern of involvement. So HRCT plays a key role in the diagnosis of hypersensitive pneumonitis and detection of its fibrosis. The indeterminate category is used when any pattern of pulmonary fibrosis is present without any specific features of hypersensitive pneumonitis. So HRCT has been categorized in as typical or compatible with hypersensitivity pneumonitis for both hypersensitivity pneumonitis and fibrotic type, and also in indeterminate type of HB for fibrotic hypersensitivity pneumonitis. So the diagnostic categories of non-fibrotic hypersensitivity pneumonitis based on CT patterns is shown here. So in the typical fibrotic, non-fibrotic HB, any of these of the features in the first column should be present, such as profuse, like poorly defined centrilobular nodules of ground glass opacities affecting all lung zones, and inspiratory mosaic attenuation with 3 density sign, and inspiratory mosaic attenuation and air trapping associated with centrilobular nodules, and also lack of features suggesting any other alternative diagnosis. So when these features are present, it is designated as typical non-fibrotic hypersensitivity pneumonatic features. Now, when there are centrilobular nodules of ground glass attenuation that are not profuse or diffuse and not associated with mosaic attenuation or lobular air trapping, and there are patchy or diffuse ground glass opacities and mosaic attenuation and lobular air trapping without centrilobular nodules or ground glass abnormalities, and there is any lack of any feature suggesting an alternative diagnosis, then it is regarded as compatible with non-fibrotic hypersensitivity pneumonitis. So here, this is a poorly defined centrilobular nodules of ground glass opacities in 3 different patients with patient with non-fibrotic HP, showing the range of CT appearances. As you can see here, 3 different types. For example, in the first one here, you see typical non-fibrotic HP with profuse centrilobular. I'm not sure if the image is very clear, but it shows like with profuse centrilobular nodules in the upper lobes mostly, and the centrilobular location is recognized by the fact that the nodules are separated by clear zones from each other and from the pleural margin. And in this one, the picture B, there's like typical non-fibrotic HP with more subtle ground glass nodules. Here it's demarcated with a yellow circle here. And on the other picture here you can see very sparse nodules with these are compatible with hypersensitivity pneumonitis on this area here. Now the 3 density sign of non-fibrotic hypersensitivity pneumonitis, which is shown in these pictures here. I'm sorry, the picture A is here, so it's fully not visible. So that it is an inspiratory CT image with patchy ground glass attenuation in the blue line here, the blue area, so blue circle here, and it has lobules with preserved, that is normal attenuation. Okay, like that's a yellow area. This is the normal area, and it has the lobar decreased attenuation in this area. So when these 3 signs, 3 different densities are present, is called the 3 density sign of non-fibrotic hypersensitivity pneumonitis. Now in the image B, it's an expiratory image that shows numerous lobules with decreased attenuation representing air trapping, which shows a little bit darker areas in this CT scan image. And on this figure here, it is an inspiratory image of another patient that shows the diffuse ground glass attenuation, the blue area here, you see here. And then, and adjacent to it, the lobule is of a preserved normal area, the blue circle here, the yellow circle in this area, okay? And it has multiple lobules with decreased attenuation that is shown in this area here, okay? So 3 different densities are shown in this picture here. And on the picture D, you see that's an expiratory CT image which shows numerous lobules of decreased attenuation representing air trapping in these areas here. Now, the diagnostic CT categories for fibrotic HP based on CT patterns. Now, in the typical fibrotic HP, CT signs of fibrosis with either of these signs should be there, which has profuse, poorly defined centrilobular nodules of ground glass opacities affecting all lung zones, and In the inspirative film, there should be a mosaic attenuation with 3 density signs that I just explained, and there should not be any feature suggesting any alternative diagnosis. The features that are labeled as compatible with fibrotic HP, the CT signs should have patchy or diffuse ground glass opacity with patchy, non-profuse centrilobular nodules of ground glass attenuation, and it should also have mosaic attenuation of lobular air trapping that do not meet the criteria for typical fibrotic HP. And there should not be any other feature suggesting any other diagnosis. And if the CT signs of fibrosis without any other features that suggest of hypersensitivity pneumonitis, then it is called the indeterminate type of fibrotic hypersensitivity pneumonitis. Now here again it shows the 3 density pattern. Now it's a highly specific image pattern for the fibrotic HP. That is in the first one here. This is the inspiratory image, and this is the expiratory image from a patient with hypersensitive pneumonitis demonstrating 3 different densities. Now you see the red stars here. These are the ground glass, high attenuation ground glass opacities, and the lucent lung region of decreased attenuation and decreased vascular regions are shown by these red arrows here. Okay, and the normal lung is the black arrows, like we shows here. This is the normal lung here. Okay, so these are 3 different signs. Now this is another image, coronal image of fibrotic HP. You can see the upper lung predominant reticular abnormality with architectural distortion and traction bronchiectasis seen in this film. So these are different CT terms used in the diagnosis of HP. Okay, centrilobular nodules, ground glass opacification, mosaic attenuation, and 3 density signs that I have just explained, and other forms of mosaic attenuation, and lobular air trapping and fibrosis. Now, the role of bronchoalveolar lavage lymphocytes in the diagnosis of hypersensitive pneumonitis. So, BAL lymphocyte raises the probability of HB, and none of these investigations are sufficient. Only one investigations are not sufficient to diagnose hypersensitive pneumonitis alone. So BAL, if BAL has like more than 30% of lymphocytes, then it has high specificity for fibrotic hypersensitive pneumonitis. It can help to distinguish fibrotic HP from other forms of fibrotic interstitial diseases such as IPF. And however, the absence of BAL lymphocytes does not exclude the diagnosis of hypersensitivity pneumonitis. So, interpretation of BAL lymphocyte is not entirely straightforward diagnosis for fibrotic HP. So, the lung biopsy, if multidisciplinary review of clinical, radiological, and bronchoalveolar lavage findings fail to establish diagnosis of hypersensitive pneumonitis, then there is an indication for lung biopsy. However, as I have previously mentioned, that we have to see the patient's condition and the chances of or the risk of complications. So these guidelines, the new guidelines emphasize that lung biopsy must be considered as a last resort. So for only in patients with low risk of complications and when all other diagnostic approaches have been exhausted. So both the ATS and JRS and ALT suggest that transbronchial lung cryobiopsy can be considered for suspected fibrotic HP. If the clinician is experienced in performing these type of biopsies and they have the means of managing the complications. So histopathology is very important when we get a biopsy, Both the guidelines give similar criteria for histopathologic findings in both fibrotic and non-fibrotic hypersensitivity pneumonitis. So we go into the management. Like there's no established algorithm for pharmacological treatment in cases where an inciting agent is identified. Avoidance and remediation are essential in aspects of hypersensitivity management. So avoidance is the only thing that will stop the inflammatory process. Currently, there are no established guidelines for pharmacological management for HB. Immunomodulating medications are commonly used, such as prednisolone and mycophenolate and azathioprine. Some data suggest that the strongest benefit of corticosteroids in patients with non-fibrotic hypersensitivity pneumonitis. However, there is no evidence to support the long-term benefit of corticosteroids in patients with hypersensitivity pneumonitis. Now, few retrospective studies have shown improvement in post-vital capacity or DLCO with the use of mycophenolate and azathioprine. And there was a retrospective study of rituximab shows that its use may stabilize the lung function in some of the patients. However, the ATS and ERS and all the respective societies combined together from the guideline in 2022 on progressive pulmonary fibrosis suggests that therapeutic benefit with nintedanib irrespective of the specific ILD diagnosis. So this is the only thing that only medication that has been given therapeutic benefit. Thus, this nintedanib may be tried for patients with fibrotic HP manifesting progressive pulmonary fibrosis. So immunomodulating medication like in non-fibrotic patients is not medications such as with steroid or sparing agents can be used in non-fibrotic cases. Then nintedanib added either in combination or monotherapy without immunosuppression in cases of fibrotic HB with progressive disease. In summary, HB is a complex disease with heterogeneous presentation and clinical course. The diagnosis is very challenging, and recent guidelines of both ATS, JRS, and ACCP provide similar diagnostic algorithms. These can help clinicians with diagnosis in newly diagnosed interstitial lung diseases. Research is needed to improve diagnostic certainty in various aspects, and genetic predisposition, validated exposure questionnaires, establishing bronchoalveolar thresholds, and specific antibody testing are also needed. Finally, the data to guide treatment of HP is limited. The strong need for clinical trials and other research to address the treatment for both fibrotic and non-fibrotic HP. Thank you.
Thank you, Dr. Ismail, for that comprehensive lecture. So the forum is open for discussion, and we can allow a few questions. And Dr. Muhammad Ismail is also has joined online.
Professor Wells, thank you for an excellent overview.
In fact, I'll come and sit down. I'm basically Daisy.
My question is about diagnosis. In a region where tuberculosis is common, histology is often not helpful, and on EBS TBNAs, sometimes gene expert ultra becomes positive. So my first question is on that, and what would be an approach to that? If in the event you get a gene expert ultra positive on your EBS TBNA, clinically, radiologically, we are thinking sarcoid.
I was thankful that my title was management, and it allowed me to sidestep diagnosing sarcoid in a TB endemic area. And I'm also aware that the most insightful statements have been made from India. But working in the confines of the Brompton Hospital, you can nonetheless review the literature. And I think it is really a matter, isn't it, that you're constantly aware of the possibility of TB when you suspect sarcoid. And then the second principle is it's a much worse mistake to treat TB with steroids than it is to treat sarcoid with anti-tuberculous therapy. So your road to disaster is failure to think of and identify TB. Now that said, we had a very elegant dissertation yesterday on how you could look at CT very carefully. You could reach the conclusion that TB wasn't plausible with an experienced radiologist, and you could also identify in other cases the possibility of concurrent TB and sarcoid, or indeed a sarcoid reaction to what was essentially TB. And what I'm really saying is there isn't a single test that is going to carry the day, but you have to have a very low index of suspicion that you're being fooled, and there really is tuberculosis there. Now, what do you then do in the way of a number of tests to pursue that? I think a good old-fashioned tuberculin skin test is helpful, because if you've just got sarcoid, that should be negative. In a way, it's more helpful than the interferon gamma tests. Now, I think as well that if you're in any doubt, you should obtain histology and culture it. So I think you go to great lengths, but it's all down to likelihoods on your first evaluation. So I don't think there's a single magical test which deals with the problem. It's just index of suspicion. I tried to get an answer in South Africa. I had to talk on this topic. You know, they took me from the UK to tell South Africans how to diagnose sarcoid in TB pandemic areas. And I thought that was surreal, so I said, I'm going to get this wrong. Please tell me at the end how I've got it wrong. But actually, they didn't do that. It went quite well. But the answer is that you have to ask and ask and ask. And if you're in doubt, you've got to go the extra mile with tests. And what does come through is if you've got biopsy confirmation of sarcoid and you've cultured for TB, whatever additional tests you add, you're on reasonably secure grounds at that point with negative cultures.
If I may ask a second question. Now, we have spoken about sarcoid and also HP, which are basically granulomatous diseases. What do you see the role of TNF-alpha inhibitors, and is there TNF-alpha inhibitors in the treatment of these granulomatous diseases? And do you see any difference between the TNF-alpha inhibitors and their users in these diseases?
Firstly, I don't think anti-TNF therapy has a role in hypersensitivity pneumonitis. We have no data on that. Can I just add there's an issue with big statements about no average benefits in HP cohorts, say with steroid. It's individual cases, whatever treatment you're using. In an individual, has steroid produced a response? Do you get a decline when you withdraw it? I think the guideline statements have to be clunky because HP is a number of different responses in different individuals. Now let me go to sarcoidosis, and I think correctly the guideline has anti-TNF therapy as third-line therapy. It's behind the traditional agents, especially methotrexate, but the family of drugs that follow on from steroid, and so anti-TNF is reserved downstream, and you always have more worry with it in a TB pandemic area, of course. So it's definitely third-line therapy, and in the lungs, I do think it's moderately rare to have to use it. It's far more frequent in neurosarcoid, lupus pernio, sometimes in cardiac sarcoidosis, but in lung disease, you really are talking, I believe, in compliant patients with logical therapy. You don't usually need to go to third-line therapy.
So I'm asking a similar question with regard to the TNF-alpha blocking agent. So if I have a patient whom I am treating with systemic steroids and the patient went into improvement or slight remission, and then I changed into, after being on a prolonged course of steroids and changed into steroid sparing agent, as introduced methotrexate as a steroid sparing agent, and while on methotrexate, if the patients relapse, when I reintroduce steroids, can I consider TNF-alpha blocking as for the long term as a steroid sparing agent?
Well, let's talk this through because it is case by case and it depends whether the patient has relapsed on what is still a moderate dose of prednisolone. If you've withdrawn therapy and the patient has relapsed, what you know is they hadn't relapsed on 2.5 milligrams of prednisolone daily. They go to a drug that is less toxic than high-dose steroid. So I think it's case by case, and it's often the problem with guidelines. The point I was making with HP, you get these clunky average statements, but you know, we all know, that you're looking at the performance of a drug in a given patient, the manifestations of disease, existing side effects, and you're working it out case by case. The guidelines are important. Obviously, they give you averages, but most patients aren't average. I'm not sure if that answered your question completely. You're saying it did. That's good if you're saying that. I didn't quite hear everything you said.
My question is to Dr. Ismail. I think he's still online, is it? We are often hampered when looking for an agent in HP. How important do you think in our part of the world antigen panels in coming to a diagnosis of sarcoidosis? So sorry, in HP, I mean.
Yeah, actually, yeah, that is the most important thing, actually, to identify an inciting agent. But I think the available panels in our part of the world is not like sufficient. We may not be able to identify an inciting agent. So it can be tried. If he finds one, then that will be easy. But sometimes in our environment, for example, for most of the time, that when the patients finds an inciting agent in their own household, then it may be very, very difficult for them to completely avoid it. However, if trying with available antigen panels, it will be very helpful. And most of the cases that we have seen in our country, most of them, they have from their working environment. So in those cases, some are able to avoid, and those who cannot avoid, they have to change their job. So if you find one, yes, that will be helpful.
Quick question for Professor. It was interesting to see the data on PRED 40 and 20 in terms of outcome. Now, are we moving out of pulse methyl PRED, I suppose, particularly in the context of cardiac sarcoid?
No, I don't think we are. So in the study of Saja Halduria, there was exclusion of patients with really dangerous sarcoid. So what we are talking about is the more routine use of steroid. And I think the case that you beautifully presented yesterday is exactly that sort of case. So the FVC, 69%, but disease had been present for only 6 months. You're worried about progression to danger, and you're using something that is more civilized. Now, in the past, people have used 40 milligrams, 60 milligrams, and what the study shows is that in a context like that, a dose of 20 milligrams daily for 6 months, you get identical rates of relapse when you stop therapy. It's almost supernaturally similar. And this has been the case in a great many diseases. People start with draconian doses, and with time they work out that you don't need to poison patients to that extent. Now, in cardiac sarcoids sometimes, and there's not time to go into this, you can make a judgment that disease is less dangerous, but if you don't suppress inflammation, you're likely to get ongoing scarring, loss of ejection fraction, and you can use a gentle cardioprotective dose. Sometimes you're dead worried, and you know you've got to switch disease off, and that's when you use methylpred. But that context doesn't apply to the Durius study.
Professor, I think we are running out of time, but can I take the privilege, have the privilege of asking you one?
Certainly.
This is about hilar lymphadenopathy in sarcoid, mediastinal and hilar lymphadenopathy without any parenchymal involvement. We see patients with hilar lymphadenopathy, and the treatment recommendation is that you don't have to treat these patients. The lymph nodes will regress on their own with time. But in practice, we have seen patients who go on to have these lymph nodes and sometimes progressive, and most of these patients have cough as their main symptom. So in such a scenario, without any parenchymal involvement, what's your opinion on management of such patients?
Well, I think you have to acknowledge, and this is very rare, that just occasionally lymph node enlargement is so spectacular that it may compromise mediastinal structures, and I'm putting that to one side, and I'm talking about the more typical scenario. You won't have symptoms due to the lymph nodes. You may have symptoms associated with the lymph nodes, but in that case, you're judging the symptoms and quality of life, and you're not introducing therapy for lymph nodes. And I don't think we have any evidence at all that lymph nodes by themselves are dangerous, except in those very rare scenarios where you can actually develop pulmonary hypertension because lymph nodes are compressing vascular structures. Now that's very rare, and let's say it once and stop talking about that. And other than that, I don't think you have to treat a serum ACE. I don't think you have to treat enlarged lymph nodes because there really are no other downsides. Now you said something though about progressive enlargement with time. And what I will say is this, that in a sarcoid patient where you've had stabilization of lymph nodes, if you then start to see aberrant behavior, you have to worry about that very rare association between lymphoma and sarcoidosis. And that's when you're repeating a scan. You're looking to see if there's something different now about the nature of nodal distribution. And so that is a circumstance not when you pour in steroid at that point. You instead get worried about differential diagnoses. But I'll stand by the fact, don't treat lymph nodes per se.
Thank you. I think we should close our sessions. Yes. We thank all the speakers for their thought-provoking and very comprehensive lectures. Thank you very much.
Thank you.
Thank you very much for that insightful session. So please remain on stage. Please remain on stage, please. A slight error was made when introducing the chairpersons for Symposium 7. The session was chaired by Dr. Vatsala Gunasinghe and Dr. Vijitha Senaratne, Senior Consultant Respiratory Physician. I apologize for any inconvenience. Now, I cordially invite the chairpersons to present the tokens of appreciation to the speakers. Dr. Manal Raman, Dr. Amila Ratnapala, Professor Athol Wells, next up, let me invite the Academic Chair of SLCP, Professor Dushanta Madhakethara, to present the tokens of appreciation to the chairpersons. Thank you very much, sir. Ladies and gentlemen, we cordially invite you to enjoy the tea which is now served outside. The session will recommence at 11:30 a.m.